this episode of International Kavirtv programming, as well as Danishcast podcast that is available on iTunes and Spotify. I am Nizam Missaghi from Arizona. I am delighted to be your host for today. And I am also delighted to introduce to you our guest speaker who has gifted us his time out of his busy schedule in the laboratory at Washington University to join us. He is a colleague and a dear friend of mine, Dr. Nima Mosammaparast. Let me introduce you to Dr. Nima Mosammaparast's background. I'm going over his bio here. He is an associate professor of pathology and immunology at Washington University in St. Louis, Missouri. He received his medical degree from the University of Virginia, where he also received his PhD in microbiology. He did his residency training in pathology at Harvard's Brigham and Women's Hospital, where he was also chief resident. After he completed his research fellowship, he was on the faculty at Harvard Medical School and Boston Children's Hospital, where he served as associate director of infectious disease diagnostics. He moved to his current position at Washington University in 2012. He's the author of many peer-reviewed articles by acclaimed scientists like himself, and he is a foremost scholar in the field of pathology and immunology, and we're very glad to have him here today with us. Welcome to our program today, Dr. Mosammaparast.
Thank you very much. It's a pleasure to be here.
We have a particular program today where we thought that there is so much anticipation around the topic of vaccinations. And I thought that it would be timely and very useful for the audience to understand the process of vaccine development, what costs are associated with developing and undertaking such endeavors, why does it take so long, and what can we expect from these vaccines in the battle in the current pandemic that is unfolding and affecting every facet of our life. And so I figured that I prepared some questions to present to you to open the conversation. And I think that it's really difficult to speak about vaccinations in isolation unless if we also have a little bit of an understanding of immunology, because at the end, vaccines are a form of treatment and form of medication or administration to patients that really invite our immune system to act in a way that we want it to in facing with a particular pathogen. So this program will focus on vaccines, but let's talk a little bit about the immune system. What comes to your mind as a scientist and a physician when we talk about the immune system and its components?
Right. So the immune system is very multifaceted, and it's quite challenging to compare it to other systems of our body. For example, can't really compare the immune system to the cardiovascular system. It's not a single centered organ like the heart that pumps blood through vessels to deliver oxygen and nutrients throughout the body. Nor is it like the gastrointestinal tract, where the purpose is to digest and absorb nutrients. So the immune system is very multifaceted. It begins with simple physical barriers, such as the skin, right? So we have, the skin actually helps to protect us against bacteria, fungi, and viruses to some extent. We know that people who have suffered skin burns throughout much of their body are significantly immune compromised. So it begins with that barrier protection from the skin. But we also have multiple components that range from the antibody production, right? So if you have a foreign material, foreign protein, for example, that may be produced from a bacteria or a virus, you have cells that produce antibodies to combat against those foreign elements. But you also have cells such as T cells or other cells that actually are able to kill other cells, including infected human cells. If a human cell is infected with the virus, it could potentially identify that and kill that cell. But there are also other components of it that are still not fully understood, such as what are called innate lymphoid cells or NK cells. So these cells are able to combat foreign elements in ways that are not related to the immune system learning that there is a foreign material present. And so they have elements of the adaptive immune system, such as the B and T cells, but they also are able to respond without being previously challenged to a certain pathogen. And so all of this is to say that the immune system is very multifaceted. There are many different components to it. And so when we're talking about having an immune response to an infection or as a result of a vaccine, we really need to consider all of these different components in the response.
Perfect. And it also appears that the immune system needs to function optimally, not necessarily too strongly and not necessarily too weakly. It has to be in some sort of a level of equilibrium or balance, where patients with very low immunity, whether acquired or genetically so, may be more at risk of being exposed to certain diseases. The people whose immunity or whose some component of immunity ends up being overactive may end up having their own immune system attacking some part of their own cells and causing chronic illnesses known as autoimmune diseases. So this is a system that not only battles outside invaders and pathogens, but also has the capability to really make our own lives very difficult if it's not kept in check and optimally functioning.
That's right. So this concept of self versus non-self is a major theme in our understanding of immunology. How does the body know, or how does the immune system know that something is foreign versus self? Now, during development, our immune system trains itself so that things that are of self are not recognized and do not activate T cells and B cells, for example. At the same time, there are people, as you suggested, where this process goes awry, and so they're not capable of discerning self versus non-self. In fact, one of the simplest examples of overactivation of the immune system is with seasonal allergies. So our immune system is, in that case, responding to something that's relatively benign, right, such as pollen. And if our body didn't have such a response, which includes, sneezing, runny nose, and whatnot, we wouldn't really be harmed by the pollen. But that is our immune system recognizing something that's foreign and trying to get rid of it, in the process making us somewhat miserable.
Right, absolutely, very well said. Now let's move on a little bit to vaccines, which really are a way to stimulate the immune system in the way that we desire to stimulate it. So vaccines obviously have a long history in medicine that dates back to 1796 with the discovery of the smallpox vaccine by Edward Jenner. And they are made with different techniques, but they all have the same goal, which is present the healthy body with a weakened or killed virus, or perhaps a disease-causing component of the virus to generate immunity. Once immunity has been established, if a person comes in contact with the actual virus, he or she would ideally not get sick. That is the true definition of the efficacy of a vaccine, meaning that it does what we want or intend it to do. Some vaccines, like the measles vaccine and perhaps the smallpox vaccine, have been extremely effective where some diseases have been nearly eradicated. Whereas with some others, such as the influenza, we've had less success in eradicating, and perhaps we've used vaccines only to mitigate the morbidity and mortality of these diseases. Would you kind of give us a little bit of an overview of now, as we deal with this novel coronavirus, what can we expect and how this particular virus lands in this efficacy of vaccines and what you expect?
So frankly, it's a little bit hard to predict. Until vaccine development moves further, it's hard to know exactly how things are going to pan out for the coronavirus. So you gave some examples of vaccines that are effective and ones that are less so. Let's take even more extreme example, HIV, where there's essentially no effective vaccine, despite numerous international efforts to develop those. Now, there are, interestingly, individuals that have a remarkable immune response to HIV and are able to largely suppress that virus with their own immune systems without treatment. Now, work that's been done in studying those individuals has found that there are certain antibodies that those individuals create against HIV that are able to stop the virus. However, virtually everybody else is not capable of producing those specific antibodies to damp down on the virus. And so, and there are numerous reasons that are quite complex and not fully understood why it is that we can't get people to actually produce those antibodies. So part of the reason why some viruses are more challenging to make a vaccine against is that they mutate. HIV is one of those examples. Now, these individuals that have essentially produced their own antibodies against the virus have been able to create an antibody to a region of the virus that does not mutate, because if it did, it would not replicate properly. And so that is the challenge. Can we actually produce a vaccine that creates a response to a part of the virus that does not mutate? Now, that's not necessarily a problem with most viruses. With influenza, that's a challenge, because influenza is not only capable of mutating during its replication cycle, but the genome of the virus is segmented. And so there are actually pieces of, in this case, RNA that come together to form influenza virus. And so you can imagine if you have two different influenza viruses infecting the same cell, a hybrid virus can come about from shuffling these different segments of the influenza genome. There are other examples of viruses that are DNA viruses that you've mentioned, for example, such as smallpox, HPV, the chickenpox virus. So these are DNA viruses, and for the most part, they don't mutate as much because replication of DNA is, generally speaking, less capable of mutation than replication of RNA. Now, that's not the full answer as to why some vaccines tend to be effective and others do not. Some of it just has to do with our ability to produce the immune response appropriately to the virus. Now, one of the things that's been mentioned quite a lot in the press is the ability to produce antibodies against the coronavirus or any other virus. And one of the things that I want to highlight here is that that's not the only component of the immune response that we need to think about when we think about vaccination. Certainly that's a part of it, but it's not the whole answer. So anyway, the long story short here is that the ability to actually produce a viable vaccine really depends on multiple factors, some of which are innate to the virus, some of which really relate to our own immune systems.
Perfect. If you were to guess whether the vaccine that would be developed against the coronavirus would be closer on this spectrum to something like influenza vaccine versus something like the measles vaccine, where would you think it would fall?
I would predict it's somewhere in the middle, and because I'm just optimistic of how things are going, I would imagine that it's going to be closer to measles. There is actually a vaccine for cow version of coronavirus that is relatively effective. That's been used for veterinary purposes, and this example allows us to consider the likely possibility that a similar vaccine can be produced for COVID-19. Now, there's one of the issues that I alluded to earlier is that the antibody response to COVID-19 seems to go away quickly. But it seems that that's not the only thing that exposed individuals have in terms of their immune response. And so even though this antibody response may fade, the immune principles that are at play go beyond the antibody response in this case, it seems. And so people do seem to have longer lasting immunity than just a month or two. Now, that being said, it's possible that the immune response may need to be boosted every couple of years against this virus. But we also have the same kind of thing happen with other things that we get vaccinated against, for example, tetanus.
That's correct. In development of vaccines in particular, we hear about phase 1, 2, and 3. Would you briefly tell us what each of these phases entail and why we should go through such rigorous processes before a vaccine is available for mass immunization?
Right. So actually, even before a phase 1, there are preclinical research that is necessary to begin trials on humans. So the phases that you refer to are specifically referring to trials on humans, beginning with trials for efficacy in phase 1. But before that, there are preclinical trials, possibly on mice, possibly on non-human primates, to build the idea that a particular vaccine may be efficacious. So these phases that you refer to, as I mentioned, are related to the scale of the actual attempt to demonstrate safety and efficacy. And the spectrum of importance is safety in phase 1 to efficacy in phase 3. So phase 1, generally these trials are small, under 100 people, and different doses of a medication, in this case a vaccine, is given to determine if there are any dose-limiting side effects that are observed in these small individuals. The maximum tolerated dose is estimated from these phase 1 trials. Phase 2 trials expand on this small phase 1, usually involves hundreds of people, And you're starting to look at not just the safety in larger numbers of people, but trying to estimate whether or not there is efficacy. Phase 3 trials involves thousands of people. And this is where you're really looking not just at safety, because it's certainly possible that, you know, there are side effects that are not seen in smaller numbers of people that would become visible when you have larger numbers of people, but you really are looking at efficacy. And so where we are right now is that there are about 150 possible vaccines, both within the preclinical all the way into the phase trials that you mentioned. Now, as you can imagine, the numbers of individual vaccines that are going in phase 1 versus phase 2, you know, there's a decrease because the process takes time. We really need to make sure that there are no side effects to these vaccines, or minimal side effects, or acceptable side effects, and that we're actually seeing an efficacious immune response. We can't have people who are vaccinated who are not well protected. So these are the two major concerns that are in scientists' and clinicians' minds when going through these trials.
So with efficacy, what we mean in medical terms is, does the vaccine really establish what it promises to do, or what you intend it to do?
That's right.
Such as you give the patient the treatment, the vaccine, the medication in this case, and then you hope that you have some metrics to measure whether the person has immunity, or perhaps follow that patient to see if the patient gets exposed to the virus, whether they would show signs and symptoms of the disease itself. And so I think that's very important. And on the safety side, I remember, I believe from the 1970s, where there was a particular flu vaccine that caused a progressive neurological disorder where Guillain-Barré syndrome, where patients ended up having loss of sensation and even movement in hands and feet that could have ascended all the way up to their diaphragm. And so this safety portion is very important. As much as there's so much anticipation to have these vaccines, it could very well be that if we have mass administered a vaccine that is not safe, we would end up harming more people than doing them good. And so I think this is very critical. That's probably part of why we have to wait for so long.
That's right.
Until we are certain that what we're bringing to market is both safe and efficacious.
The other part of it to remember is that there are examples of vaccines that not only are they not efficacious, but in certain individuals actually make the disease worse. So there is a not necessarily well-known series of studies on dengue virus, where the vaccine in that case actually made the disease worse in some individuals. So we want to also make sure that that component of the efficacy is considered. And the other part of the timeline that we need to think about is production. We're looking at hundreds of millions, if not billions, of doses of this vaccine that need to be produced. And that's not trivial. You know, the various forms of the vaccine that are out there, they could be recombinant protein vaccines. So what this means is a particular segment of the coronavirus is cloned and amplified so that the protein component of that is produced. That needs to be highly pure. And then it needs to also mimic the actual protein on the coronavirus. If those conditions are met, then it can perhaps function well as a vaccine. There are other viruses that are RNA viruses, or excuse me, RNA vaccines, I should say. And the idea here is that the coronavirus is also an RNA virus. And if you produce a small segment of that RNA, that the body can actually produce that protein that the coronavirus would also be able to produce, and then that induces an immune response. Those are actually relatively new. there are being utilized now as a way to potentially make a coronavirus vaccine. However, the efficacy of those has yet to be demonstrated widely.
Is there concern that if you were to inject the RNA of the virus, it could come and take over the machinery of one of our cells and then suddenly become a virus itself and be disease causing itself?
Yeah, so there's really no probability of that at all. The fragment of RNA that is actually used is not capable of replicating into a virus that autonomously is able to amplify itself in our body. It's only a segment of RNA that is intended to produce multiple copies of the protein. The advantage, the potential theoretical advantage of using an RNA is that an RNA molecule can make hundreds or maybe thousands of molecules of protein that can then be recognized by the immune system as potentially foreign and then mounting this immune response. So that's the idea behind using an RNA vaccine strategy.
Interesting. You had said specifically that this needs to be highly pure and obviously very closely mimicking the structures of the virus. I would assume that there's also another challenge that whatever you produce has to be very stable in solution, because you're going to produce this in the billions and put it on shelves at so many places. And if over time the half-life of this material that you've produced is small, it could still be that you had a very well working product that by the time it actually made it to the patient, it was not very effective.
That's right. And there are actually some vaccine strategies that actually package a particular coronavirus protein into another essentially harmless virus. So for example, there are examples of trials ongoing with an adenovirus-based vaccine. So adenovirus is another virus that affects humans. There are many of them around. They cause anything from the common cold to gastrointestinal disease. And these have been oftentimes used as basically a benign virus. You can actually take components of it out so that that causes no disease, but it's able to actually still infect cells. And so one vaccine strategy here is to take an adenovirus that's essentially benign, put in a component of the coronavirus genome, and then basically what you do is create a hybrid virus that is essentially attenuated, and that works around this problem that you brought up, because if you have a virus that is capable of living in the environment for some time, and it has a tiny bit of the coronavirus protein being expressed on its surface, then that's a way to mitigate this issue of stability.
Wonderful. And you said that we have nearly 150 different efforts going around the world, essentially trying to develop a vaccine. And I'm sure that each of these look at different pathways or different ways of producing. Some of them may have overlaps or maybe the same kind of vaccine. And I wonder if the prize goes to first to market, even if it's not necessarily the most efficacious, or how do we compare all of them to make sure that the one that is most likely to mitigate the effects of the pandemic ends up on the shelves all across the globe?
I think this is a very evolving situation, rapidly evolving situation. And I think that just like the influenza vaccine, where there are versions of it that can be injected intramuscularly, or there are ones that are intranasally administered, there will probably be multiple COVID-19 vaccines on the market. And I think only time will tell which one or which ones are going to be the ones that are more efficacious. I think, again, the main issue I anticipate in the next year is not necessarily going to be efficacy in the short term, but the availability to produce the hundreds of millions, if not billions, of doses that are going to be necessary. So I think that the capacity for industrial scale production may actually become rate limiting in the foreseeable, in the near future.
Right. You alluded to this, and I want to revisit it for a moment. We have data that antibodies of recovered patients from COVID-19 can fade and become undetectable within a few months of recovery. Do you think that these patients lose their immunity commensurate with the fading of antibodies? And what assurance can we have that if we develop antibodies in response to a vaccine, we would have long-term immunity if the antibodies produced in response to the vaccine follow the same fate?
So this is part of what I think has given some people panic, that people who have had COVID and who have recovered, that their antibodies fade. But as I alluded to earlier, the immune system is multifaceted, and what has been clearly proven is that a major component of the immune system's response to the virus is cell-mediated immunity. So in other words, you have T cells and other cells that are capable of actually killing cells that are infected with the virus. And so the inability to detect an antibody against the coronavirus does not necessarily correlate to a loss of immunity. And in fact, we have other examples where the immune system's response is primarily that of a cell-mediated response. And we need to actually measure that and not just antibodies. And the example that I'm thinking of right now is for tuberculosis. So we have the ability to actually measure the response of our T cells to tuberculosis antigens in vitro as a surrogate of determining whether or not someone has been exposed or someone has had previous an immune response to tuberculosis. So in that case, obviously, the antibody measurement is not necessarily useful because the antibody response is not a huge component of the response to that foreign antigen.
Okay, perfect. I think you're referring to the Quantiferon Gold laboratory that can be drawn as a, so that really is a metric for cell-mediated immunity, and Quantiferon is not looking for specific antibodies.
Right, in that case, what's happening is you're taking the T cells, the peripheral T cells from the patient and exposing it to a tuberculosis antigen to see whether or not those T cells proliferate and produce interferon, which is a marker of those T cells recognizing that antigen and responding to it. So it's possible that we would have that type of a test available for COVID as well. It really remains to be seen what element of the immune system is going to be prognostic or diagnostic of immunity. I think that the tests that are out there right now for measuring COVID antibodies, really, it's kind of the Wild West. What they actually tell you clinically is unclear. And so in our institution, while we offer that test, it comes with a very strong note that a result either way does not necessarily tell you clinically whether someone has been exposed or has immunity.
Yeah, they're very imperfect. I would assume that if we were to solely depend on antibody testing, we would create a very difficult prognostic scenario for our epidemiologist colleagues, because as they want to do random testing within certain populations to define the disease burden, they would not necessarily know what percentage of the population has actually been exposed to the disease, because many of them who've been exposed and recovered and their antibodies faded over the next few months may appear to be completely non-exposed to the virus,
Right.
even though their T cells may have cell-mediated immunity and perhaps the recipe to kill this virus. But if we don't have a specific test for that, it's very hard to define the disease burden.
Yeah, I think that these tests may have some utility for looking at a snapshot in time of who has been exposed to coronavirus in the near past. I think that their ability to do anything more than that is going to be quite limited.
That's right. Okay. So another question that I have is, we already have phylogenetic evidence that the novel coronavirus has mutated and various changes in its genome have been detected. Does this concern you that the vaccines in production may have less efficacy with the continued changes, or do you feel confident that enough structures within the virus have remained the same to not escape immunity that's conferred by a vaccine?
Right. So coronavirus certainly does not have the capacity to mutate that HIV or influenza does. So that I want to make very clear. The amount of sequence information that's out there clearly does suggest that specific mutations are happening, and in fact, using those sequence information, we can actually determine where regions of outbreaks are related to others. So we can tell, for example, if somebody traveled from abroad to the city of Chicago, that a particular strain of coronavirus came along and infected a number of individuals, just as an example. That being said, there are mutations, but it's not as if these mutations make it impossible to design a vaccine that's going to be efficacious. And there's actually one other thing that I want to address, because it's related to the topic of mutations. There's a particular mutation that appears to be dominant in the United States right now, and there was a group that published a couple of studies that strongly suggested that this particular mutation is more easily transmissible and may have greater ability for pathogenesis. The data for that is still controversial. I think it really remains to be seen whether that mutation has some kind of survival advantage or advantage to spread more easily.
Mm-hmm. Got it. Now, while we're on this topic, and this would be one of my final questions, is would you please tell us about the difference between developing your own immunity from your body as opposed to getting convalescent plasma from a patient who's recovered from COVID in recent memory and being given that as a way of conferring immunity to you?
So clearly the antibody response is a component of our body's immunity to coronavirus. And if you have the capacity to actually transfer an antibody from an individual who was previously infected to one who is infected but does not have immunity and may be suffering from the disease, you may be able to mitigate some of the effects of the illness because of those antibodies. However, there are two issues here. One, again, is that we're missing a whole other host of responses when we simply transfer convalescent plasma, right? So, you know, the T cell response, the cell-mediated response, other tissue-dependent responses are obviously not present in convalescent plasma. The other thing that I think is very important to consider is that the dose of convalescent plasma that would potentially be required for treating even one individual is unknown. And so how much would you actually give to a patient, never mind hundreds of thousands of patients? And so I think that while that may remain part of the arsenal of our response to COVID, it's still going to be limited simply because of our ability to have it mass produced.
Got it. And let me ask this final question. I had seen in the literature that there is a suggestion, although this is not proven, that certain vaccines may create this non-specific immunity, perhaps this non-specific stimulation of our immune system that may help us in facing the novel virus, the coronavirus, such as the BCG vaccine, which is not in widespread use in the US at this time, but in some developing countries it is, and it was a vaccine developed to help people mitigate the effects of the tuberculosis pathogen, as well as a recent report that perhaps people who have recently received the MMR vaccine, the measles, mumps, rubella vaccine, may have a certain level of non-specific stimulation of their immune system that may help them fight the coronavirus more effectively. Do you have any comments on such developments?
I would actually be skeptical of these data. And I think that goes back to the idea that our immune system really is advanced because of its ability to adapt to specific antigens or bacteria or viruses. I think the idea of having a generally more active immune response so that you can fight infections better, it's really hard to say how that would be potentially useful against this coronavirus or any other type of virus. So I think that the time will really tell whether or not these news reports turn out to be true. But I think just based on the principles of immunology, I think it's rather unlikely that they would have a major effect.
Got it. Well, thank you so very much for giving us so much of your time, Dr. Mosammaparast. I am very pleased to be your host today and for you to share your knowledge from both the clinic and the laboratory side. I am very pleased to follow your career from your days at Rochester, at University of Rochester, all the way through to Virginia, to Harvard, and now at Washington University, with such a wonderful academic pedigree and such wonderful and impactful publications in very prestigious journals. Really appreciate your time, and we hope that we will have more such programs together to bring further information to the viewership of this program. Thank you very much for being with us, and I hope to collaborate together more.
Absolutely, my pleasure.